All right, so my watch is, well, this the clock on my computer says 17:10:04 on the dot, so I guess we can start. So I'm just going to briefly introduce the speaker here, but before I start, a few housekeeping rules, and I guess a few notes for those of you that haven't or are joining us for the first time. So this talk is being recorded. We record all our talks, and it's going to be shared publicly. There's some crude editing that's going to take place, but most of it is actually going to be shared publicly. And then, oh, just a few people want to come in. So the talk itself is a part of two postgraduate courses that we help coordinate. So there's an information science course called Information Systems and Technologies for Information Management. So it's a part of the Master of Library Information Science postgraduate course. And then there's another postgraduate course which is it's actually available in this Department of Computer Science. So CSC 5741, that's data mining and warehousing. It turns out that these two groups of people enrolled for the courses are interested in different aspects of these talks. So the people enrolled in the MLIS program are, for the most part, interested in the records management part and things to do with information systems. So I know most of the questions, if any, are probably going to be centered around these different information systems you use to make certain decisions at work. That's you, Jacob. And then the people doing the 5741 course are most interested in the more technical aspect of data analysis. Now, we haven't gone in a stage where we start discussing, I guess, the things that they find really exciting, that's machine learning aspect, but we have got into a stage where we've discussed, I guess, the most important aspects of the typical data mining pipeline. So yeah, that's that. And then I see I have their colleagues from the department as well. I see Mr. Wale is joining us. It turns out that he happens to be one of the experts we have in the department when it comes to records management. So I know he'll be very much interested in the SmartCare aspect of the talk today. Great. So just to briefly introduce the talk and the speaker. It turns out that it's a part 2 of last week's talk. Jacob was unable to give his part of the talk because of a technical glitch. So the abstract is, is as follows. The Center for Infectious Disease Research in Zambia runs one of the largest ART programs in Zambia and conducts various types of research studies relevant to Zambia and the region in general. So the talk is going to go into specifics of what data collection analysis tools are used for the ART programs and two ongoing research studies. But the two ongoing research studies were actually introduced last week, so that part is not going to be discussed. So Jacob has a BSc in a BSc degree in computer science from the University of Zambia and a Master of Science in Information Systems and Management from the University of Greenwich. In his role as data manager, he leads the reporting unit in various research and programmatic projects. And this is impressive. He has 7 years work experience where he served as software developer on the SmartCare project. This is exciting. For the people coming from UNZA, I don't know if people are aware, but UNZA Clinic rolled out SmartCare towards the end of 2018, if my memory serves me right. Now, I haven't gotten my, I don't know if it's a card or something yet.
Care card.
I think I should go and get my card. This is weird here. But just to mention that this thing is happening, the rollout is taking place. I'm not sure how far they've gone, but hopefully Jacob can speak to that. Thank you, Jacob. The floor is yours.
All right. Thank you so much, Lighton, for that introduction. And I'll get straight into the presentation. Right. So what we're going to look at today is our data management processes around our Achieve program. So when I talk about the Achieve program, I'm talking about the ART program that is run by CIDRZ. Achieve stands for Achieving Control of the HIV Epidemic. So the Achieve program is a PEPFAR-funded project that CIDRZ runs. It's been running for the past 4 years. Now we're going to the 5th year of the program. All right. So,
sorry, there's a comment there that your screen is not shared. I think you unshared it or something. Maybe you want to reshare it. Or I don't know if you hadn't yet gotten to the stage where you shared it, but.
Let me just check. I'm quite sure I shared it, but anyway, let me redo it. Okay, I hope we can see the screen now.
Yes, we can. Thank you.
Okay, fantastic. I think I may have unshared it at some point. All right, moving on. So the outline of this presentation will look at an overview of our data collection and reporting processes. We'll talk a little bit about the tools that we use for data collection in terms of source documents. We'll have a discussion around SmartCare. I think that's probably the most interesting part of this presentation for everyone participating. And we'll look at how we compile and measure our data. We'll also look at the final part of our reporting process, which is the aggregation. And then after that, we will talk about how we have used SmartCare data to be able to provide an enhanced level of patient care to our ART clients. So now I just want to encourage everyone to take note of the questions that they have. If anything I say doesn't make sense or you don't understand it, please just take note. I understand that most of what I'm going to say is probably going to be new to a lot of people, but please take note of the questions and then we can have a discussion towards the end. Right. So why do we collect data? So as I mentioned earlier, CIDRZ runs an ART program. And as part of the requirements for running that program, we need to keep track of our progress, okay? So what are we aiming towards, right? We are all aware of the 95-95-95 targets that were set by UNAIDS. So these are the targets that we are aiming towards. In short, we want to make sure that as we are collecting data, we're monitoring the process of meeting these targets, okay? Now, to go into a bit more detail, the things that we monitor from a high levels perspective are issues around how many people have been tested, okay? How many people have been diagnosed with ART and how many people are virally suppressed. So the end goal of the ART program is to test as many people as possible who are living with HIV, identify the positives, and of those positives that you do identify, 90% of them should be put on treatment. And then of those that are put on treatment, they should be virally suppressed. Okay, so viral suppression is basically means that the amount of the HIV virus in the body needs to be below a certain count. Okay, it needs to be below 1,000 copies per milliliter. So these are the overall targets that we are tracking as a program. Now, I couldn't go into the specific details of the different indicators that we track because it might not be relevant to this discussion, but if there are people who are interested in having that discussion, we can have it at the end of this presentation. The data that we collect is collected from health posts, clinics, first-level hospitals, and referral hospitals. So a health post is a small facility like, say, Chalala Health Post or Bauleni Health Post, a very small facility. So from the small facility, the next level of data that we collect is at the clinic. So in most cases, what we find is that health posts actually feed in their data into the clinics. And then we also have another level above that, which is known as first-level hospitals. So first-level hospitals are places like Chilenje First-Level Hospital, Mutale Reference, Chawama First-Level Hospital, Kanyama First-Level Hospital. When I talk about referral hospitals, I'm talking about places like UTH and Levi Mwanawasa hospitals. So at all these different levels of healthcare, we collect data. In terms of our composition, right, we have 24 data associates in Western Province and 75 in Lusaka. The Achieve program actually runs in these two provinces. Previously, we used to run in Southern and Eastern Province as well. So in terms of our data associates are the ones who actually go on the ground in the health facility collecting data at the point of care, okay? Above that, we have our data coordinators who provide the supervision for the data associates. And in our office here, where I'm seated, we have data managers like myself who provide the overall supervision in terms of strategic information, providing guidance to the data coordinators on how to collect data and training on new data collection tools and so on and so forth. And then the lead of the department is the head of the strategic information unit. So this part of the presentation now will go into a bit more details regarding our processes. The first three steps here represent administrative processes, so I won't focus so much on that. So basically, we want to make sure that in these three steps, we want to make sure that the team on the ground has enough in terms of resources, transportation, food, fuel, allowances, etc. That's what this means. But for the purpose of our discussion today, we'll focus more on what happens from this fourth step going forward. So data collection happens weekly, monthly, and quarterly, as well as annually, okay? So when a team collects data from the facilities, okay, that data is collected onto tally sheets. And these tally sheets are basically counts of specific indicators that we want to keep track of. And then apart from the manual counting of specific indicators, we also have data that is entered in SmartCare. Now, I will leave the discussion on SmartCare to a later slide. So once data is collected into FIMS and SmartCare, again, FIMS, I'll talk about it a bit more in the later slides. What we do is that this data is submitted or entered into FIMS, and as well as transport databases are collected from SmartCare. I'll talk about this a bit more, in a bit more detail, bear with me. And then once this is done, the data is compiled and merged at HQ, and then we start a verification process. The verification process is basically to ensure that the data is correct. Once again, I'll talk about this in a bit more detail later on. Once the verification is done, we submit the report for a monthly or a quarterly reporting, depending on the time period we are in. Yeah, so these other final steps just represent some automation steps that we do to make sure data is submitted to our funder. Yeah, so I was talking about our data sources. We have registers, patient files, electronic health records, as well as lab results. A register is basically a very large hardcover book, which is formatted in a table to collect specific information about a patient. So, for example, you have a register for a first ANC visit for a pregnant mother. It will contain information about that mother, about their vitals and the like. A register for an ART patient will contain information about the patient and the drugs they collected. So all these different documents exist in our facilities, and they collect information about different types of patients from different types of interactions that they have with the facility. When I talk about patient files, I am referring to a folder-like document which contains paper records about an individual patient. So the difference between a register and a patient files is that a register contains one large hardcover document contains information about multiple patients, right? While a patient file contains information about an individual patient. But a patient file can be a very large and thick document depending on how long that patient has been on treatment. When I talk about electronic health records, I'm referring to electronic versions of patient files. That's the simplest explanation I can give. And when we start looking at SmartCare, we'll go into a bit more detail about that. Lab results are basically A4 paper records which contain results from a central lab which a facility submits samples to. Some facilities have local labs at the facility, and they're able to conduct some level of tests at the facility. But for most things like viral load, they're conducted centrally. All right. Moving on now to how SmartCare is deployed across the country. We may depending on who's participating in this call, you may or may not have heard of SmartCare. So SmartCare is the National Electronic Health Record System that we have in Zambia. It's a Ministry of Health product supported by PEPFAR. Okay, so in terms of deployment, we have 3 modes. Okay, we have what is known as eFirst, eFast, and eLast. So when you go to a health facility now, right, most of these large facilities, for example, Chilenge First Level Hospital, when you walk into the outpatient department or OPD, you'll notice that the nurse or whomever is attending to you has a laptop, and this laptop has some device connected to it. Okay, so in this particular situation, SmartCare is deployed in eFirst mode, meaning that as you are having the interaction with the provider, a provider in this case means a nurse, a doctor, or some other healthcare provider, as they're interacting with you, they're actually capturing the information that they're getting from you in real time into your electronic health record. Okay, that's what's known as eFirst. And in eFast mode, it's a bit different in that while your information is captured in your electronic health record, it's not captured in real time. Okay, so you can have the interaction with the nurse. The nurse or the doctor or whoever will write your vitals or your symptoms on a piece of paper, and they'll capture this. And at some point, while you're in the facility, they'll either enter it themselves or give it to a data person who enter this information in SmartCare. And by the time you leave, they'll update your electronic health record and give you a copy of your electronic health record on a smart card. In eLast mode, this is what you find in most rural facilities and in most facilities where we haven't yet deployed eFirst. What you'll find is that most likely you won't see any laptop or computer being used, but all your information will be captured on pieces of paper or forms, and then this information will be filed into a filing cabinet or a filing room, and then at some point someone will open that file and update your electronic health record. So now the situation varies in the sense that some facilities which have eLast now actually have data staff dedicated to entering this data. But in most cases, you find that some facilities, very remote facilities, especially in Western Province, they don't have any data staff. So what happens is that one of our team members routinely goes to these facilities and does this update on a laptop that they carry. Okay, and that way the patient electronic health record is updated. Something else worth mentioning on this slide is that some of this information might not be relatable in that it might not be visible during the time that you go to or you've been to these health facilities that we have around. The reason is that eFirst deployment in SmartCare is a relatively new strategy. It's probably been happening in the last 2 years or so, where there's really been a push from the Ministry of Health to make sure that everyone who has a record in SmartCare is able to update that record in real time. Okay? And all new patients are able to be registered in real time, and that they're able to go back home with electronic health records on a care card. Yeah. Moving forward, so I've already talked about the type of data we collect. In SmartCare, historically, we've been collecting ART data, lab, and pharmacy data as well. So before the rollout of eFirst, there was a heavy, I would say, a heavy use of SmartCare in the ART department. So if you went to the facility to collect drugs for malaria, you might not even know what SmartCare is, or may not even be aware of it. But now, with the rollout of eFirst, what's happening is that every single interaction that you have with the facility is captured in your electronic health record. Okay, so it doesn't matter whether you're an ART or not, you will have an electronic health record. But again, I must emphasize to say that you may not have seen this personally, but I think going forward, you begin to see more and more of this, and it will become more and more familiar. But for those who've been on ART, or those who are familiar with the ART program, this is not necessarily a new thing. So I did touch on care cards in my previous slide. So a care card is essentially a copy of a patient's electronic health record, which is copied onto a smart card. So what is the significance of a smart card, you might ask? A smart card is basically an innovation which was added to SmartCare that allows continuity of care, all right? Now, why is continuity of care important? What is continuity of care? Continuity of care is basically the ability to have a continuous health record that's not broken up into several different pieces that are in different health facilities. Continuity of care means that when you go to facility A and they capture your symptoms and they give you drugs for whatever ailment you may have, when you go to another facility, because you have that care card, okay, the provider or clinician who sees you at that other facility will be able to see the history of your interaction with the previous facility because you have a copy of your electronic health record on your care card. Your care card has your entire history from the time you start in your interaction with SmartCare up to the time that you die, right? And now the vision of the people who started this project is that every Zambian should have an electronic health record, a single electronic health record. The other benefits that this may have is that for patients who have who are on ART, they may not be very conversant with the drugs that they're on, and suppose they find themselves in a situation where they run out of drugs. Okay, for example, if I'm on ART, I live in Lusaka, I collect drugs at Chilenje First Level Hospital. Okay, I have a care card, but I'm not very familiar with the types of drugs that I collect. I'm not familiar with my drug history. I just know that I have to take a certain amount of pills on a particular day, on a particular time period. So maybe I don't know the name of the drug. So when I go to another facility, they'll slot in my care card and they'll be able to see the history of the drugs that I've been on. And from that, they'll be able to determine what drugs to give me. Okay. I've already touched on SmartCare, so I will not go so much into it in this slide, but what I want to talk about is DHIS2. So apart from SmartCare as a data collection, we also make use of DHIS2, right? So the reason we introduced DHIS2 is that we wanted to increase our data collection and reporting efficiency. Right? Before the introduction of DHIS2, what would happen is that we support about 245 facilities. We would collect individual databases from these 245 facilities for data that's not in SmartCare. And for this, I'm referring to non-ART related data because we are required to report on things like PMTCT, TB, and the like. And so for that data, we developed some other systems to be able to collect patient level data. So this was a very labor intensive and time consuming process. And so we realized that we're spending a lot of time processing data as opposed to looking at data. Okay, so we investigated DHIS2 and we found that it would actually work for us in terms of our back-end reporting processes. Okay, so when we deployed DHIS2, we found that it was able to meet most of our needs in terms of developing forms for data entry, all types of forms in terms of aggregate and patient level data. We're able to create reports on it and data could be viewed in real time as opposed to what we used to do before where the system was extremely manual and we would spend days or several hours working on it. Okay. Now, you may be asking yourself, why is it that we have SmartCare and DHIS2? So just to give you an understanding, the reason we have SmartCare and DHIS2 is that SmartCare is a point of care data capture application, okay? Meaning that we collect information about the patient's interaction with the facility using SmartCare, okay? But SmartCare in itself, while SmartCare has reports, it does not have the features to enable us to report on multiple facilities in real time, okay? I'll go into a bit more detail on that later on. DHIS2, in this slide, I've labeled it a back-end application, meaning that it complements what SmartCare does as a front-end application. SmartCare is client-facing. DHIS2 is a back-end, meaning that we feed into DHIS2 what is in SmartCare, as well as the interactions which are not in SmartCare that the patient may have with the facility. So with these two applications, we're able to have a well-rounded system of data collection and reporting. I've already touched on our weekly, monthly, and quarterly reporting schedules. So now, to get into a bit more technical details around SmartCare and DHIS2, my colleague already touched on this previously in his presentation last week around the back end of SmartCare and FIMS. So what we do is that we have a monthly reporting, weekly and monthly and quarterly, like I said. But for our heavy lifting, it starts with the monthly reporting cycle. So on the 5th of every month, we receive what is known as a transport database from SmartCare. And this transport database is basically a copy, right? It's a copy of the database that a facility has, a SmartCare database that a facility has. It contains all the patient's interactions at that facility, okay? It's an encrypted file that is submitted to our office here in Lusaka. And what we're able to do is that we're able to merge all these different transport databases into a single database so that we can have a look at what's happening. Let's check
presentation. So sorry about that. I think someone accidentally shared their screen as well. Just, I hope it's fixed now.
All right. Okay, no problem. So I was talking about transport databases. We merge all these databases into a SmartCare server here at our office, generate reports for them, and export them to Excel for analysis, right? So another step that we do is that for data that is not captured in SmartCare, this is mostly non-ART data. It's captured in our DHIS2 instance. And what we do is that we get the data from SmartCare and get the data from DHIS2 instance, which we call FIMS, and then we merge it into a single document that we're able to look at and look for completeness, look at analysis, and then share that for verification. I've mentioned the word verification a lot, so I'm going to go into a bit more detail as to why we need to verify our data. Number one, the reason we need to verify our data is that our data is quite often bad. Secondly, sometimes you find that not all the data is collected on time. And thirdly, some facilities usually have data entry backlog. These are usually the ELAS facilities that I alluded to in my earlier slide on the SmartCare deployment models. So when we have bad data, you find that the data is incomplete, meaning that we do not have the complete set of data that we expect to receive at a particular point in time. The data does not make sense. You find that, for example, you have more people on, just a crude example I can give is that if, for example, you have expecting to put 5 people on treatment because 5 people tested positive, you find that 0 people were put in treatment, but that's an anomaly. Right. I hope this is the slide which everyone last saw. I talked about the different steps that we do for the submission of TDBs from SmartCare, as well as the merging process that we do for the TDBs. And then I talked about the reports that are generated from FIMS and exported into Excel. Then now I was looking at the verifications. Right. So I was basically talking about why we have bad data and the reasons around that. So on the second point here, we have when data is not collected, right, what you find is that in some cases, you find that a register is not found at the facility, or a register has been hidden, or a register is incomplete. there are all sorts of scenarios that we find ourselves in at facility level. So what we do is that we have interventions around this, right? What we do is that we call the data associates and we tell them or actually in some cases speak directly with someone at the facility to make sure that they're able to complete the source documents that we can have a complete data set. Another situation we run into is backlog. So backlog in this case can mean an incomplete patient interaction at the facility. For example, if we know that in a certain period of time, a patient goes to the facility, or a certain number of patients go to the facility, but when we run our reports, we find that the pharmacy numbers are not adding up, or they are not complete. So we go back and forth with the facility to make sure that all the pharmacy records are up to date and our numbers can reflect that. Another example of viral load of backlog is the issue of viral load results not captured in SmartCare. So this is an issue because then we're not able to report on our viral suppression of viral load coverage. So in this situation, we normally, in cases, facilities that we can reach, we provide additional resources to that facility to make sure that they're able to complete their backlog for viral load, and we're able to report on an accurate viral load coverage and suppression. Now, why do we go through all this effort? Okay, it's important because we want to have good quality data, and good quality data means that we can have an accurate measure of our performance as a program, and also we can assign the right amount of resources to activities in the ART program. Because if you have false information about what's happening with the program, then you won't know where to put the resources. Right, I've spent a good amount of time talking about our data processes. Now I will go into some other area, which is some of the things that we've done in terms of trying to improve our patient care based on the data that we collect in SmartCare. Yeah, so I spoke a great deal about pharmacy and clinical issues, but now let me go into some practical examples that we might be able to relate to. So now, when a patient is on ART, it's important that they don't miss their clinical visit. Okay, it's important that they don't miss their pharmacy visit. What is the difference between a pharmacy and a clinical visit? A pharmacy visit is basically a visit to a facility to collect ART drugs. A clinical visit is a visit to the facility to have an interaction with a healthcare provider so they can do an assessment of the health of the ART client. Sometimes clients have both pharmacy and clinical visits on the same day, but sometimes they're on different days, depending on the interval that is decided by the clinician. So one thing I mentioned at the beginning of the presentation is that it's important for us as a program to put a certain number of people on treatment based upon our targets, right? So we have targets to meet as an organization, and so we have to make sure that no patient is left behind. One intervention that we came up with is the sending SMS reminders to ensure that our patient retention is improved. By patient retention, I mean that our patients should be able to go to the clinic on their appointed date, okay, either for a pharmacy visit or a clinical visit. So what we do with this intervention is that 24 hours before a scheduled visit, we send an SMS to remind the client of their visit. And then 24 hours after an observed missed visit, we also send an SMS reminder just for the client to go to the facility. Now, how are we able to do this? Okay. Using SmartCare, we have a record of a patient's entire visit history, including their current visits and their appointment dates. So what we do is that we check for SmartCare for all patients who are supposed to visit the day before, okay? And we also compare that with the patients that actually came, okay? And then after we do that, we look for patients who are not in this, patients who didn't actually come to the facility based on, as compared to those who are supposed to come, and we come up with a list of patients who missed their visits. We do the same thing for those who have missed their visits by more than 30 days. Okay, and the importance of this, like I said, is to ensure that patients are not missing their visits, they're collecting their drugs, and they're having their appointments with the providers. We also send reminders for the visits that are coming the following day. Now, just to get into a bit more technical detail, this is just a snippet of code that we run as part of this intervention. So what you're seeing on the screen, for those who are very familiar with SQL, is that we have a record of pharmacy visits, correct? In this table here, CIDRZ pharmacy visit. And then we have their visit details in terms of the next appointment date. And so when we compare, what we do is that we look at the next visit dates, and we extract that data. We make sure that each of these patients who are supposed to come on the following day are sent an SMS. So I don't want to go through so much details about what's happening in this SQL, because it's a little bit outside the scope of this discussion, but just to give you an idea of how much technical know-how you need to have to be able to pull this off. From a high level, what happens every day is that the facility, there's some software we've installed at all the facilities that's we're running this intervention at. But what this software does is that it pushes visit data to our HQ, our server here at the office, and it basically comes in 3 sets. There's a set of patients who missed appointments yesterday, a set of patients who are coming for visits tomorrow, and a set of patients who've missed their visits by more than 30 days, okay? And once you collect this data on our server, we send SMSs according to the type of visit, according to the type of intervention that we're focusing on those 3 sets of patients, okay? This goes to our service provider, and the client receives their SMS. We're currently in the process of analyzing this data to give us an idea as to whether or not this intervention is actually yielding the results that we expected, in the sense that we want to know whether patients are actually coming back to care, or rather those patients that we send SMSs to are actually coming back to care on time for their clinic visits. Perhaps at another point in the future, we could come and share the results of that analysis. Okay. Yeah, so that's pretty much it regarding the SMS reminders intervention. I'll now talk about what we did with regards to
Maybe we should be back in a second. Okay, I think you're back. You're back.
All right. So I was saying that, as we're all aware, COVID-19 spreads through close contact with individuals who are infected. And an ART clinic represents a high-risk area in terms of transmission of COVID-19. Okay, so now we know that our ART patients need to come to the facility to collect drugs every 3 months or so, right? And we know that when they come into the facility, most likely they'll come into contact with someone who has COVID, and they might get infected. So on top of their HIV infection, they'll have a COVID infection, and that will just mess up the quality of their healthcare, which is already compromised. So now, in order to fix this or to mitigate this, what we came up with is an intervention to put as many patients as possible who are on ART on 6-month dispensation. What that means is that instead of patients coming to the facility every month or every 3 months, they'll be coming to the facility every 3 months. In turn, that will reduce the patient population at the facility at any given point in time. So instead of having, say, 50, 60, 70, or 100 people visiting a facility on a particular day, you have maybe 20 or 30 or around that number, a significantly reduced daily appointment list. So in order to pull this off, we had to basically write custom scripts that were able to identify patients who are on ART, had less than, say, 1 month of drugs. And what we did was that we were able to pull out the contact details from SmartCare and call them back to the facility. This is actually an ongoing activity as we speak. It's happening. And so I would love to come and share the results of this at some point in the future as well to the team. Yeah, so at this point in time, I will stop because the other part of the presentation is actually what was presented last week. And I will invite questions from the team.
Wow, thank you so much, Paul. I'm sorry, Jacob. Paul and Jacob, both names from the Bible here. But wonderful presentation. It was enlightening. It never gets old. I mean, I know Mshashu came through last year to give somewhat similar talks to last year's cohort, but it's always nice to have you guys come over. I've always thought, I mean, it's amazing what people are up to in the country. We just meet each other at malls without knowing the important work that you do. But anyways, lots of important questions here. I know people in this 5310 will probably be interested in data preservation. You know, there are privacy issues, records management. So if there are questions, people, please feel free. The floor is open.